Hi, this week on the Nurse Coach Duo, we're interviewing Brooke Kalisiak. She's a pelvic floor therapist that's going to talk to us about the genitourinary syndrome of menopause. We're going to dig into what it is, what we can do about it, and when we should seek treatment. It's a very important subject that and I are both passionate about, and we hope that you'll listen to get the important information that you need. Before we dive in, just a quick reminder. This episode is for educational purposes only and isn't medical advice. If you're dealing with a health issue, please check in with your healthcare provider.
Hi, welcome to the Nurse Coach Duo. I am Angie McGuire from Coach Angie.
Hi, and I'm Jen Schroer from Clarity Health and Wellness. And today we have Brooke Kalisiak, that is a pelvic floor therapist, meeting with us today. And we're super excited to have her to talk about genitourinary syndrome of menopause. And for ease, we are just going to say GSM for the rest of this, this episode. Yeah. So let me tell you about Brooke real quick before we get started. So she is a graduate of Princeton University, where she was a member of their Division I women's basketball team. She completed her master's in health and science and physical therapy in 2002, and then a doctorate in physical therapy in 2008 at good old WashU here in St. Louis, where we both live. Brooke opened Legacy Physical Therapy in 2009 in St. Louis, and she offers specialized pelvic floor therapy services to the public. And she's also grown that to 2 practices with 5 physical therapists, which is so great. Brooke has a passion for helping women and men enjoy healthy, active lifestyles, restoring dignity and confidence in bladder, bowel, pelvic, and sexual function without relying on pain medicines or surgery. Her mission is to educate the public about the importance of pelvic health. And if that's not enough, Brooke has also published professional literature related to pregnancy and exercise, and continues to help other professionals in the field of pelvic health by lab assisting for continuing education courses and teaching at Washington University. And I will add also that she has an awesome Instagram feed. So if you are on Instagram, you should go follow her, because you will learn so much information. So welcome, Brooke.
Thank you. Thanks for having me. I'm excited to chat with you. And thanks for putting the GSM out there right away so that I don't have to stumble over genitourinary syndrome of menopause, because it's a mouthful.
It is a mouthful. I don't know why they do that, but at least they gave us an acronym, right? Not just, yeah, that makes it a lot easier. So yeah, let's just jump in. You want to just tell us what is GSM? Let us start with the basics.
Yeah, so let's back up a little bit to what is the genitourinary system. So the aptly named, it is our genital area. So in females, we're talking about the vagina and the vulvar region, everything kind of encompassed in that, all the way up to our uterus and our ovaries. And then the urinary side of it, so our bladder, urethra, and all of the muscles and nerves and everything that supplies around that area. So we're talking about this entire area, which, I never talk without having my pelvis present, but when we're thinking about it, it's this whole kind of front triangle area of the pelvic, plus all the associated organs that are on the inside there. And this is an area that is heavily influenced by estrogen. And so, which helps to kind of maintain this healthy tissue, hydration, and elasticity and ability to move. And so when women start to transition into menopause, they're in perimenopause, and the estrogen levels start to fluctuate. And then after they hit menopause and the estrogen levels have basically just dropped off completely, we can see some pretty significant changes in this area. And it used to be called vaginal atrophy, was like the fun term that the medical world gave it, and which really only talks about the vaginal component of it. So more recently, the term has changed to the genitourinary syndrome of menopause, so GSM. And just for fun, there is also a GSL, genitourinary syndrome of lactation, because they've found that women who are postpartum and breastfeeding have these similar estrogen decreases as in menopause, and can have the same types of symptoms. So a postpartum mom can be dealing with some of these like menopausal like syndromes and symptoms if they are breastfeeding because of the estrogen changes. So it's a mouthful, but it's a better way to describe kind of what's going
Mm-hmm.
on in this time because there's a whole host of different issues that can happen during this time frame. The syndrome itself can be related to vaginal atrophy, which is kind of the shrinking down of the vaginal tissues, and that can also include dryness, burning, itching, irritation in the vaginal canal. I had a patient the other day said it feels like sandpaper, like when something's trying to slide in, it just feels like it's sandpaper and rough, and yeah, I could imagine that wouldn't feel very good. And so one of the common things that people say is they're dealing with pain with sex, and that might be related to the dryness, or it might be related to the thinning of the vaginal tissues that are there, or it could be in response to the muscles kind of tensing up and tightening around it because of the changes that are going on. On the urinary side, this is a time where a lot of women start to get increased urinary urgency, frequency. They might start to have burning with urination. This is a common time in life where a lot of women start to deal with frequent or recurrent UTI symptoms. And that's one of the most common things that lands people in the hospital and then unfortunately lands women in nursing homes, and that because they can't deal with these bladder issues, and so if there's things we can do to kind of affect that, we're going to affect kind of the longevity and the quality of a person's life moving forward. And then the last symptom that's common during this time is pelvic pressure or heaviness or fullness because of the thinning of the tissues and the lack of the support in the area. A lot of women can start to feel like their pelvic organs are starting to kind of sag down or fall into the vaginal area. And this is globally known as pelvic organ prolapse, but more specific names can happen just depending on what organs are prolapsing. So we could have where the bladder tips back or the rectum tips forward or the uterus comes down. Everything can kind of come down in that area, and it can get a little crazy.
Yes, and this is where you come in, Brooke. This is good.
So
And
yeah.
thank you so much for going through all those like symptoms and also mentioning GSL too. I've been actually just reading about that a bit, and really recognizing some of the symptoms that I may have had, during that time of my life, and related to, the decrease of estrogen, ultimately. So yeah. So when people are having these symptoms, we know that, that women can start having these symptoms in perimenopause, maybe around 15%, we know, and then much greater postmenopausal, up to, I've seen 84% of women, and it's probably more than that, right? That have these different symptoms in menopause. And it is one of those things that signs it's not going to improve, right? Our tissues are changing, they're thinning, they're, as you've already described, all those symptoms and what's happening to, our body. So, what should women do, right? When should we seek help? What would you say? Because, yeah.
So seeking help, the earlier the better, which we women are notoriously great for sitting on things and putting everyone else's needs ahead. And I think a big part of that too is that a lot of women, I'm happy to start to see there being more and more talk about menopause and perimenopause happening now, because so many women are unaware that they might be in their mid 30s and going through perimenopause already. And that they're like, nah, that's some, 50s, 60s, like I got a while. And it's like, no, like perimenopause can start 10 to 15 years ahead of the menopausal transition. So first and foremost is having that awareness that these changes your body is going through, and we're talking specifically about the genitourinary changes, not to mention all the other host of changes that our body can go through, the brain fog, the hot flashes, just all of the weight gain and changes that where people aren't realizing that those are all linked together. And so I'm hoping that the general kind of public awareness that about perimenopause and menopause is starting to take effect, and people realize that these changes they're experiencing can be related to their decline in estrogen, and that there are things that they can do about it. And so first and foremost, I would recommend talking to your OBGYN or your primary care at either making a special appointment or at your annual appointment. And I'll also kind of put a little caveat with that is unfortunately, not all of the practitioners are very well trained in what can happen during menopause and perimenopause. And so if you're not getting answers, don't stop there with your one provider, and that you may have to go seek someone out. There's a wonderful organization, the North American Menopause Society has a search feature to be able to search for practitioners who are specialty trained in menopause issues. And so it may be time to kind of go seek out a practitioner who has that specialty training if your OB is kind of writing it off. It's like, oh, you're just getting older. That's normal. And that's one of, I hate that. Like these changes are common, but they're not normal. And so there are things we can do about it. And so trying to find a knowledgeable practitioner is the first step, which may be your OB. They may have the training and that's great, but don't, if they're writing off your symptoms, don't stop there. Kind of keep reaching out to find the help that you need.
Yeah, and like you said, it's kind of getting the national exposure right now with Oprah back on like March 31st at this
Yeah.
special, and I think that people while watching that and getting this kind of exposure, people are starting to go, oh wait, that's me, that's me, that's me, and I'm hoping that, like you were saying, Brooke, that now that you can say, oh, other people are having this problem. Halle Berry thought she had, herpes or what
Mhm.
have you. Then you're like, it's going to kind of take a little bit of that shame away, that people will start seeking
Mhm.
help a little bit quicker,
Yeah.
because they are, I mean, this is, like Angie said, one of those that doesn't get any better. So you actually need treatment. And as nurses, both of us been at the bedside, we've seen these septic patients from the
Mm-hmm.
urinary tract infections. And it's I mean, I've experienced it with my own family, just older, as women get older and they end up with these, and all of a sudden they aren't making sense and nobody understands. Everybody thinks, oh, they've got dementia or what have you. And it's like, no,
Mhm.
it's a UTI and we just
Yes,
need to give
UTI.
them some antibiotics. So yeah, it's really
Mhm.
important to understand that. And obviously that's the extreme. So we want to catch it early whenever, as soon as we can, and start getting treatment. So,
Yeah.
can you tell us a little bit about how a pelvic floor therapist helps with GSM? So, you talked
Yeah.
about going to your OB, but sounds like you're obviously able to help as well.
Yes. So, as a pelvic physical therapist, our area of expertise is the muscles in and around the pelvic area. So, most people know it in terms of the pelvic floor. So, if we look at the pelvis, anything that's in red down here is muscle, and it's all collectively known as the pelvic floor. And these muscles have a ton of different functions for us. They help to support the pelvic organs. They are basically what we learn to potty train with so that we don't pee and poop on ourselves. They're involved in sexual function and orgasming. They help to make our core canister nice and supportive, so they work together with our abdominal muscles, our diaphragm, and our back muscles to give us a stable base to move off of. So there's so many functions. And unfortunately, most people just know of them as, oh, they're the pelvic floor. They do Kegel exercises. And
Mm-hmm.
a Kegel exercise is a contraction of the pelvic floor, which, the muscles need to be able to do. They need to be able to contract, but they also need to be able to relax, to stretch, and to coordinate with the other muscles around there. So these muscles really kind of work in an automatic fashion for us, and coordinate with so many other muscles of the core. And so what we do as a pelvic physical therapist is kind of assessing the whole system of how they work together. How are these muscles coordinating with other muscles? Are they too weak? Are they too tense? Are there knots or trigger points in the muscles? Are they maybe strong enough, but they're not contracting at the right time? Or someone thinks they're contracting the muscles and they're actually like pushing them down and out because that's what they thought a contraction was. So in assessing all of that, we can come to some of the underlying root causes or musculoskeletal causes for issues of GSM, or some of the symptoms of GSM, like pain with sex, or urinary urgency, frequency, or leakage, or pelvic pressure and heaviness. So a lot of times these types of symptoms don't actually need a more invasive medical treatment. They don't need medication that require, that may have side effects for the person. They don't need surgeries. A lot of people, especially if this is caught early, can get better by making adjustments to their lifestyle habits and improving their musculoskeletal strength and coordination and movement in that area, and other simple suggestions so that they can really have an effect on their own body and how it kind of works together.
So you mentioned, doing this treatment with you, this therapy, and not many people not needing to further, take medication or have surgical intervention, of course. What's the feedback from some of your patients about other hormone therapy? Like if someone starts on hormone therapy or they start on vaginal estrogen, are you getting good feedback from your patients to complement physical pelvic floor therapy with another therapy?
Yes, definitely in the case of like GSM, hormone replacement therapy can be super helpful. And we have a lot of women who are doing it just as a topical estrogen cream or type situation, or ones who are doing a systemic hormone replacement therapy, and that can make a huge difference for them. So a lot of times we'll have people start with pelvic physical therapy because they seek us out or that for bladder issues, and they might be seeing some improvement, but their symptoms aren't going completely away. And we're oftentimes referring them to their OBGYN to talk about vaginal estrogen or hormone replacement therapy, because some people's bodies are just so sensitive to estrogen and just really miss it when it's not there. And like I describe it to our patients a lot of times, the estrogen in the pelvic area just helps to fluff up the tissue. And so if you have a strong muscle, but the tissue doesn't have a lot of fluff around it, we can't get that nice strong closure of the sphincter because the tissue is kind of frail and thin. But once the estrogen's back in the area and fluffs it up, your good strong contraction of the pelvic floor works a lot better for that sphincter muscle because there's this extra kind of bulk of the tissue around there. So in the case of bladder leakage issues, it can make a significant difference that way. And then again, with people are dealing with pain with sex, if that tissue is just so dry and irritated, the estrogen can be so helpful to just kind of ease that. And then we also talk with them about vaginal moisturizers and vaginal lubricant for during intercourse to help kind of through that process. And a lot of women are, especially if their entire life they haven't had to use lubricant, they're like, but I gotta use lube now. And it's like, girl, lube is your friend. Like lube is a good thing. It just makes things slipperier and just makes it a lot easier. And so helping people to kind of pick out like what lubricant's going to work well for them and then what moisturizers they might want to be using to kind of complement it. It's like we spend so much time thinking about moisturizers for our face and our face skincare routine. It's like, well, that's some pretty sensitive skin down there too. We probably, should be thinking about how we moisturize that area as well.
Yeah.
Do you have a favorite moisturizer that you recommend and you get really good feedback? Replens is one that I often talk about.
The Julva makes a good one. Julva. There's a brand called Good Clean Love that makes both lubricants and moisturizers. They're good as well. A lot of times I'll tell someone to look for one that's got hyaluronic acid in it to help kind of plump up the tissue because that's been shown to be helpful. So yeah, and I've started people sometimes where they're like, I don't really necessarily want to buy a moisturizer, but they've got coconut oil at home. And that's using coconut oil as a natural one. I was like, just put it in a separate container. It's your little bathroom moisturizer one. It's not your kitchen one. Okay. Like separate those two out. So
I love that recommendation. I've been told that before by some of my clients that's been very helpful.
No, it can be. So,
yeah, and super approachable.
Two different things. That's one thing that some of my clients get confused on is like, well, moisturizer and lubricant, same thing. It's like, oh no, not same thing.
Right.
Moisturizer, think about it on our face. Moisturizer, we want it to get absorbed into the skin and help make our skin nice and supple. We want it sucked in, okay? Lubricant, we want it to stay on the surface to reduce the friction and stay nice and slippery. There are some lubricants out there that also have moisturizing properties, but I recommend keeping those separate. The moisturizer is something I recommend putting on like after a shower type of situation so it gets absorbed well. Lubricant is for when we need to reduce the friction and we use it in that situation.
Yeah, that's a
Great
good
recommendation.
distinction. Yeah, exactly.
Yes.
Really
Thank
good
you for being
distinction.
clear on that. Yeah.
Yeah. So, I think that as we talked a little bit about, like it's difficult for women to make these decisions to come in and
Mhm.
be honest about it. So yes, sometimes we wait too long. So I wonder if you could talk a little bit about, I mean, I know some women will be like, all right, I know I waited 5 years, but I want this to be better by tomorrow.
Mhm.
Right. So, and it's understandable, right?
Yeah.
Because now they're so miserable that they're just like,
Mhm.
something has to change.
Yeah.
So regardless of like, and obviously everybody's different, but can you talk to a little bit about how long it takes maybe with physical therapy to start seeing a change?
Yeah, no, that's a great question. And yeah, everyone's a little bit different. We get that issue a lot. We get a lot of women, especially moms who have like teenagers or that now. They're like, it's too late for me now, isn't it? Like I was
Mm.
supposed to come in like right after I had my kids. I was like, it's never too late. Like our oldest patient was a 93-year-old with bladder issues who we were able to help. So our bodies are amazing. We can make changes at any point in our life. But like you said, the longer you've been dealing with symptoms, the longer it might take to
Yeah.
see a change with it. But on average, we are working with people once a week for maybe about 6 sessions or so, so about a 6-week time period. And I always tell my patients that we should start to see changes for the better in like those first 2 to 3 weeks, that your body is like, hey, like this, something about this is working. We're moving in the right direction. And if we're not, then we need to kind of reevaluate, what our focus is and how things are going. We might need to pull another team member in. That might be a situation where we need to be like, hey, you need to talk to your OB about potentially being put on estrogen in some form. And so it may be more of a time where we reevaluate and see, what other team members might need to be in place. But a lot of women, especially for like bladder issues or pain with sex type situations, they're seeing complete improvement in like a 6 to 8 week period. And it's pretty cool to see that, like, just a lot of times it can be some really simple changes. One of my other therapists had a woman in her 60s with urinary urgency and frequency just come back earlier this week for her first follow-up appointment. And just the few changes that my therapist recommended at her evaluation appointment, she's like, I'm 75% better. Like,
Wow.
I didn't realize how much of this was like my bladder controlling my brain versus my brain controlling my bladder. And so that's not always the case. That's an extreme example, but it's like cool to see, like, yeah, like when people can kind of click into it and realize like that they can have some level of control, and that sometimes the changes can be really, really fast. And sometimes we've got some more drawn out, involved things that we've got to work through to help them achieve their goals and get to where they want to be.
That's amazing.
Yeah.
Six
That's
weeks,
great.
6 to 8 weeks, man. Yeah, that's not that long in the grand scheme of things when you're feeling that way. So that's
Yeah.
great. Thank you.
No, you're welcome.
I think though it's just taking that first step, right?
Yeah.
Coming and thinking about um, having pelvic floor. There's,
Hmm.
especially for Gen Xers, who's probably much of our audience here is, we learned about Kegels and that was about it. And,
Hmm.
GSM, what's GSM? Like what on earth is that? And they have maybe urinary frequency or urgency, and they think that they're just supposed to deal with it.
Hmm.
And I love the story about the 60-year-old, or, we don't even need to put an age on it really, but it's just someone
Hmm.
coming back with like the story, of like, gosh, wow, what I
Hmm.
learned from you, and that there is
Yeah.
help out there for
Yeah.
these symptoms as we get older. One of the things I've had a little bee in my bonnet this week after the Oprah special with one of the commercials I'm not happy with. It has nothing to do with Oprah. But it was a very famous actress that we all know from our favorite TV show, Gen Xers, of ER. And she did a Poise commercial. And it was like like something that we should be looking forward to, or like, it's okay, there's poise out there for you. It really
Yeah.
should have been a commercial with, about vaginal estrogen or a pelvic floor PT, or this
Yeah.
is the help that we can give you, and ask questions. Do you have this? Then ask questions. The poise, it didn't set well with me. I'm still wound up about it, as you can hear.
I feel
So,
you there. I don't know what version of poise they were trying to sell, but
oh, it's
yeah,
the big
it was big
pads.
bad.
Like,
Oh,
yeah, I mean, no, I
for
don't
me,
know
the one that
exactly.
always gets me are like, don't worry, we've got you covered. We've got these nice lacy looking
Yeah.
Oh,
under
right.
adult
Hmm.
diapers for you. I was like, you gotta be kidding me. This is what we're selling people? Like, all right, crazy.
Yeah. Yes. So as a menopause coach, menopause educator, this is one of my favorite topics because of what I just said. Like, people just unaware, and talking about our pelvic area, which is really important, right?
Yeah.
So, um, so people feel embarrassed, and maybe
Mhm.
about that. I mean, what do you say to people, like, like, that are hesitant or embarrassed? What would be your advice on that?
First, they're not alone. And unfortunately, we aren't talking about it as much as we should. Many people haven't had conversations with their mom, their grandma, their aunts about stuff related, but like it is more common than people think. And
Yeah.
up to like somewhere, some of the studies show that like 50 to 70% of postmenopausal women will experience some of the symptoms of
Mhm.
GSM. And so that's a big percentage of people. So the other thing to say though is that don't be afraid to advocate for yourself. Unfortunately, a lot of times in the medical model, if we're brave enough to take a symptom to our doctor, a lot of
Mhm.
times we're written off by it. Like, oh, it's just a normal part of aging. Like, that's just normal. Like, you're just going to have to deal with it. When it gets bad enough, I'll refer you for surgery, or let's try these meds. And although that is advice, it's not like there's things that people can do now. And so being able to keep speaking your voice and keep seeking out the care that you need, and know that you're not alone with it, and that there is help out there, is really helpful, especially as it relates to pelvic physical therapy. I still have patients every week, even though I've Legacy Physical Therapy has been here for 17 years now. We have new patients every week who come in and like, I had no idea pelvic physical therapy was a thing.
Right.
I had no idea this could help me. And sometimes we've had patients who have been to 5, 6, 7 providers and been told all kinds of different advice. And then they finally get to us here, and they might get to us here because their friend told them about us, or they did their own research and they heard about pelvic physical therapy and they asked their doctor, and the doctor's like, oh, you might as well try it. I don't know. That's literally some of the referrals to us sometimes. And so they're here, and I'm not saying it's gone within a couple visits, but within a visit or two, we've kind of identified what the key source of their pain and problem is, and given them an answer. And a lot of times these patients are both really, really happy and really, really pissed off at the same time, that they're like, I've spent the last 5 years going to all these different medical providers, and you're telling me like my bladder symptoms are all related to a tight pelvic floor that's not relaxing, and I didn't know how to get things to relax and move it together. I was like, yeah, and they're happy that they're getting the relief at this point, but they're also pissed that they dealt with it for so long. Um, so I would love to see it be more that the conversation about pelvic stuff just keeps happening more and more. And
Mhm.
it's going to be amongst friends and stuff like that. I can't tell you how many women come and they're like, yeah, I got together with my friend group on Wednesday night and I told them all about what we did. And I was like, that's great. Like,
Yes.
I
awesome.
love that.
And
Love
then
that.
like they're all like the guinea pig, and then slowly we see like, Sally was first, and then Jane comes, and then and it's like, all right, cool. Like so like I think we're starting to see more and more of a conversation around it, but it's hard because it isn't something that's talked about as much. And as much as I hate those poise commercials, at least we're talking about
Yeah.
female bladder leakage and issues. Like, yes, I don't believe that the poise pad is the right option
Good point.
for it, but it at least is being spoken about. So if we can keep up that conversation, then it's helpful.
Yeah, I always think it's so interesting about like if you're pregnant and you have the baby sitting on your bladder, or you have to pee a lot, or you have complete all of these things that you openly can talk about because you have this visible
Mhm.
bump that allows everyone to say,
Mhm.
how are you feeling? But
Mhm.
now you're past that. You've done all those things, but now
Mhm.
suddenly we can't talk about these things. It's like
Mhm.
these, I mean, like we should actually feel absolutely just as comfortable. And I get
Mhm.
it. It's not, I mean, it's not easy for anybody, but yes, I'm hoping that the more we talk about it, and part of the reason why we want to continue the narrative and have these kind of
Mhm.
conversations on our channel is
Yeah.
because that is a big piece of it is we all need to start feeling more comfortable to talk about it and not have to whisper the
Mhm.
word and not have to, even still whispering the word menopause.
Yeah. Well,
So
and I think in the doctor's offices, a lot of times, like I think on the medical side of it, some training needs to happen in how questions get asked to patients and that, because like just looking at my own experience at my OB's office, like you come in for your annual, you fill out the little screening questionnaire, and on the screening questionnaire, it asks me, do I have urinary incontinence, dyspareunia, or fecal incontinence, which I know what those terms mean.
right.
Mhm.
But like guarantee the general public probably doesn't know what
No.
dyspareunia means. And for a lot of people, they think urinary incontinence is someone who is in a diaper all the time because they're wetting their pants all the time. They're not thinking, oh, well, when I laugh, I leak a few drops, or I stopped running because I leaked when I
Yeah.
ran. So like I don't leak, but I don't leak because I don't run anymore. And so, like the screening questionnaires are kind of misleading in a lot of offices. And then, if there's not a yes on the screening questionnaire, a lot of times, the practitioner's got 5 minutes tops with you. They don't see a
Yeah.
yes, they don't ask you about it.
Yeah.
Nor if they are asking, they're asking like, are you having any urinary incontinence? And that sounds awful. Like, no, I'm not having urinary incontinence. It's like, but if I asked, are you leaking when you cough or sneeze? Like, does a
Right.
little bit come out when you exercise? Like, if you change the questions you ask, like, I've had a lot of people who answer no to do they have urinary incontinence. And then when I ask specific bladder leakage questions, they're like, oh, yeah, well, I do that. I do that. Well, that's normal after having a kid. I was like, that's bladder leakage. That's urinary incontinence. That's not normal
Right.
unless you want it to be happening. Like,
Yes.
it's not normal. And so I think some of it is how do we ask the questions to try and get at the answers too. So.
Yeah, and people when you think about leakage versus incontinence, like it's the word leakage is, it's more okay, yeah, maybe I have no one like incontinence is a scary word, right?
Hmm.
We think that only happens later in life. And
Hmm.
so yes, definitely the words. And I hope to see those screenings change for people. But I hope
Yeah.
our audience now will know leakage, leakage, leakage. That's incontinence,
Yeah.
pay attention to that. So
Hmm.
no, that's great. That's great. Yeah, I was going to share that, I teach group menopause education courses, and I would say in each group we have one person that's had pelvic floor, and they share their story, and
Good.
I would say 100% they've had success in whatever. And it's not till usually the last class that people will open up about it. It's
Hmm.
interesting,
Yeah.
but everyone learns from it. And so to your point, like we just have to keep talking about it. And I love that you
Hmm.
have Sally and Jane and like people sharing in their book clubs. And
Yeah.
that's what we want. That's what Jen and I want,
Yeah.
and of course you do too. But so thank you for sharing all that and just normalizing it. And
Yeah.
that there's actually help out there.
Hmm.
You can have success. You
Hmm.
can feel better
Yeah.
with intervention and work,
Yeah. Yes. Yeah.
right? Got to take action on these things.
Yes, that
So
is true.
yeah.
Very true.
Um, if we're looking for a qualified pelvic floor therapist, like
Hmm.
what's your recommendation? I know we share the menopause society website with our clients
Hmm.
to seek practitioners. Does pelvic excuse me, does physical therapy have a similar website to look for a qualified, trained
Yeah.
pelvic floor therapist?
So there are a couple different ones that I usually recommend to people. So pelvicrehab.com has a great list of practitioners who have gone through their coursework. And
Oh,
then
great.
our national organization, the American Physical Therapy Association, so it's APTA pelvichealth.org, has a PT locator on that. And what I usually recommend is, especially if you're in a smaller town or whatever, start with both of them let you say, like, how far are you willing to drive? Like, start in the mileage radius that you're willing to drive and see if you find someone. And if you don't, then just keep going out until you do. And then, because these directories aren't they aren't the end all be all, they're a wonderful place to start. But the pelvic physical therapy world tends to be a small world, and oftentimes we know of where others are. So,
Hmm.
say you don't find someone in the directory until you're 50 miles away from your house. Call that clinic, ask to talk to that therapist and say, like, hey, I live 50 miles away. I can't, make this back and forth every week or whatever. Do you know someone who's in my hometown or closer to it that way? So that's one way that I tell people to kind of search for it. In physical therapy, like if you're seeing a pelvic health physical therapist, they most likely have training on the effects of menopause, on the genitourinary system, and so they're really informed that way. But there's nothing wrong with asking to speak with the therapist or asking the front desk, like, hey, is your, therapist familiar with working with GSM patients? Is your therapist trauma informed, like, especially if you've had some type of history of trauma, and making sure. Another one I tell people to ask is, like, are they working, do they have the option for, like, a closed door private treatment room situation? I have had what I consider horror stories of patients coming to us in our facility after they've gone somewhere else, where they're like, yeah, we were in this big open gym and all they did was pull a curtain around our treatment table. And I'm like, oh, no, no, that
Yeah.
sounds very awful to be talking about very, very personal things in that
Yes.
situation than that. So it's like, you can ask the facility, or am I one-on-one with the therapist in a private treatment room, or am I like one of many in a big gym with lots of people around, and I might be talking about very personal things, and so those would be some other questions that I might ask about.
Great advice. Thank
Thank
you.
you. Yeah, it's great.
Yeah. So I've given a ton of really great advice throughout this whole thing. So, but we always like to ask if you have one piece of advice that you would give a woman maybe that's managing either just midlife or dealing with what might be
Mhm.
GSM.
Honestly, it's a little bit more general, but you know your body better than any healthcare practitioner knows your body.
Yes.
And so if you know that something's not right, continue to advocate for yourself. Because unfortunately in our current medical system, that's something that you might have to do, but trust your instincts on that something's not right in your body, and continue to seek out the answers. And don't be afraid to advocate for yourself. I can't tell you how many patients end up coming to pelvic physical therapy after they finally heard from a friend, or that, because their doctor never told them about it, and they just assumed, well, my doctor didn't tell me about it, must not be something I need. And
Right.
then they end up at our office, and they end up having a great experience with it. And so they, again, it's something that you might have to be the one advocating. Don't just take it at face value of what the doctor says is law. That,
Yeah.
and you know your body better. So
Yeah,
Yeah.
I wholeheartedly agree with that.
Yes,
Wholeheartedly agree with that.
100%.
Yes. Yeah, thank
Love
you
it.
for that. Well,
Yeah.
Brooke, I know you have patients to see today, and so we want to be respectful of your time. So I really want to thank you for giving us so much great information, for normalizing this conversation. I know that our audience is going to find this super valuable. I just think that it's as Angie said, it's such an important topic for us to be talking about. So I definitely encourage everyone to follow Brooke on social media, even if you're not in the area. Some tons of great information. Find a pelvic floor therapist for yourself because it's never going to be bad to get that checked out and see what's going on and make sure that you have kind of a baseline. If you've liked this episode, please give it a like and don't forget to subscribe so that you don't miss future episodes. All right. Thanks again, Brooke.
You're very
Thank you
welcome.
so
It's
much,
great
Brooke.
talking with you. Thanks.
All right, Brooke, we like to end our interviews and our time with our guests with a little rapid fire. But first, I want to just ask you, can you spell out your Instagram? For those who are just listening to this interview, can you just let us know your Instagram and then we'll do the rapid fire?
Yeah, if you'd like to follow us on Instagram, it's Legacy Therapy. Oh, I already screwed it up. That's my website.
That's
Crud.
okay.
Wow, I'm good. Yeah, let's try that again. Legacy Physical Therapy STL for St. Louis. And that's our Instagram and YouTube handle, so you can find us there with it. So
yes, and we'll put all of this information in the description of on the YouTube channel. So that's great. Okay, rapid fire. All right, here we go. Coffee or tea?
coffee. Always coffee.
Cookies or cake?
Ooh, cookies. Definitely cookies.
Cats or dogs?
Cats. Grew up with them. Always cats.
Comedy or horror?
Comedy. Don't like horror at all.
What's your favorite self-care practice?
Working out. Currently, it's lifting weights for me. I love that one.
Good work. What's your favorite go-to energy boost? Maybe not coffee. Anything else that you?
For me, getting for like a hike out in nature. And that honestly, that really gets me going.
Nice. What are you looking forward to most in midlife?
More freedom to travel and to see different things. I'm currently an empty nester just starting this year, so really trying to figure out what that means and what that entails. So
yes, that's real for a lot of our audience, I would guess. So and it's a big transition. So one thing you wish you would have known about midlife?
That it starts earlier than you think it does, at least as it relates to the menopausal changes and that. So I'm 47 currently, and definitely for the past couple of years have been experiencing, but like we talked about, it could be even earlier than that. So I didn't necessarily realize until I got to this point that it's like, oh, this can be starting earlier than I thought it could.
Yeah. And actually that takes me back to your comment about knowing your body. We know our bodies and pay attention, and our intuition is most of the time right. Correct. So, and advocate for ourselves. Love that. Okay. Last one, forgetting names or losing your keys. What happens more?
Forgetting names. My husband knows that's my worst one. I'm bad with names. Can recognize the face, but the name is tough.
Hey, you got the faces. I think that's really important.
There you go.
All right, Brooke, thank you so much. We really appreciate your time and all your wisdom.
Oh, you're welcome. Thanks for letting me come on. It was great to chat.
Thanks. Friends, don't leave just now. I have something. This is Angie here, and I want to share with you the importance of contacting the FDA about a black box warning on vaginal estrogen. There is a lot of research out there that the majority of women can use vaginal estrogen for signs and symptoms of genitourinary syndrome of menopause. So we are going to put the link in our description to Let's Talk Menopause, where you can find a link that you can sign quickly for Unboxing Menopause. That's sort of the campaign name. So please take part. We need to get this black box warnings off of all that estrogen products that do not reach that are not systemic. They're local, and they can help so many women out there. And actually, one of my favorite docs out of DC, Rachel Rubin, says that the research has shown that we can save $6 to $22 billion to Medicare if we prescribe vaginal estrogen to women, and it can help prevent UTIs and hospitalizations. And it's just so important to make this first step to get the black box warning off. Okay, thanks, friends.